The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast, where we navigate the maze of healthcare policy and economics each week. My name is Marc Ryan, and thanks to everyone for listening in. This week's episode is titled America's Healthcare Grand Bargain: Stop Managing Claims and Start Managing Health. Before we begin, if you missed episodes 1 and 2 of this 5-part healthcare reform series, I strongly encourage you to go back and listen. In episode 1, I laid out my overall framework for healthcare reform, what I call a 3-pillar approach focused on price reform, care redesign, and affordable universal access. In episode 2, we focused on price reform, why healthcare in America costs so much, and why price variation, consolidation, and fragmented payment systems are central drivers of that problem. Today, we move in episode 3 to what I believe is the most underappreciated and most misunderstood part of healthcare reform: how we actually manage health, or more accurately, how we fail to manage health today. We will take our usual 3 breaks, so let's get right into it. Part 1, the core problem. We manage claims, not health. Let me start with a simple observation. The American healthcare system is extraordinarily good at one thing: processing claims. We decide what gets paid, what gets denied, what requires prior authorization, what needs additional documentation, what meets medical necessity, and what doesn't. We have built an entire administrative ecosystem around adjudicating claims after or before care is delivered. And to be fair, utilization management has a role. It prevents waste, it prevents fraud, it prevents unreasonable utilization. It enforces some level of clinical discipline in a fragmented system. But here's the problem. We have made utilization management the centerpiece of healthcare operations today. And in doing so, we have overlooked something far more important. We have underinvested in actually keeping people healthy. Part 2, a misaligned system. Think about how incentives currently work. Health plans are evaluated on cost control, medical loss ratios, administrative efficiency, compliance metrics, and increasingly quality scores and stars performance. Providers are evaluated on productivity, volume, relative value units, throughput, and procedural output. Patients are largely passive recipients of care. Nowhere in that structure is a strong, aligned incentive to ask, how do we prevent disease progression in the first place? Well, maybe a tiny bit in the emerging quality metric market, but otherwise, really not very much. The result is predictable. We intervene when people are already sick. We authorize procedures after conditions worsen. We manage chronic disease once it becomes expensive. But we rarely invest enough upstream to prevent those conditions from developing or progressing. Part 3, the clinical reality: risk drives costs. Let's be clear about something fundamental. Healthcare costs are not randomly distributed. They are highly concentrated. A small percentage of patients account for a disproportionate share of spending. And those patients are not random. They are typically individuals with multiple chronic conditions, poorly controlled disease states, social instability, behavioral health challenges, or a combination of all of the above. In other words, cost follows complexity, and complexity follows unmanaged risk. Part 4, clinical risk versus social risk. To understand this properly, we have to separate 2 dimensions of risk. First, there is clinical risk. This includes diabetes progression, cardiovascular disease, COPD and asthma, kidney disease, cancer, and other chronic conditions. Clinical risk is driven by disease burden and severity. But the other really important risk, second, is social risk, often called social determinants of health. This includes housing instability, food insecurity, transportation barriers, health literacy, income instability, and social isolation. And here's the critical insight. Social risk can be as predictive, if not more predictive, than clinical risk in driving outcomes and costs. A patient with well-managed diabetes and stable housing may cost very little. A patient with the same diabetes but unstable housing and food insecurity and transportation barriers may spiral into repeated ER visits, hospitalizations, and complications. Yet our system often treats both patients the same way clinically. That is a fundamental failure of design. With that, we will take our first break, and when we come back, we will continue discussing the need to pivot to real care management and managing health. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We're doing a 5-part series on healthcare reform. We are in the 3rd episode, The Need to Pivot to Care Management and Truly Managing Health. So part 5, the over-reliance on utilization management. Now let's return to utilization management. Prior authorization, medical necessity review, step therapy, formulary controls, pre-certification. These tools were designed to prevent unnecessary care. And again, they do serve a purpose. But over time, has become the dominant operating philosophy in healthcare. We ask, should this MRI be approved? Should this procedure be allowed? Is this medication necessary? Instead of asking, why did this patient need an MRI in the first place? Why did their condition progress to this point? What intervention could have prevented this deterioration? One approach manages episodes of care. The other manages health trajectories. We have overinvested in the former and underinvested in the latter. Part 6, the care management gap. True care management is fundamentally different from utilization management. Care management is proactive. It is longitudinal, it's population-based, it requires understanding who is at risk, why they're at risk, and how to intervene early enough to change outcomes. But here's the uncomfortable truth. Most care management programs in the United States are not truly transformative. They exist in fragmented silos. They are often under-resourced, and too frequently, they are optimized for reporting requirements rather than real clinical impact, especially in programs tied to quality metrics and STARS performance. Engagement can become more procedural than meaningful. Part 7, what real care management looks like. A functioning care management system would look very different. It would continuously stratify population risk, identify rising risk individuals early, integrate clinical and social data, coordinate across providers, and intervene before costly events occur. It would include chronic disease coaching, medication adherence support, behavioral health integration, home-based interventions, telehealth and remote monitoring, and community-based support services. It would treat the patient not as a claim to be adjudicated or a service to potentially be denied, but as a person moving along a health trajectory that can be influenced. On a side note, I got my first look at real care management when I was the COO of a nonprofit health plan dedicated to individuals with HIV and AIDS back in the late 2000s and early 2010s. It was in South Florida, an epicenter of HIV infection in the U.S. What was eye-opening for me was that I had two very diverse populations that I was serving. Previously well-to-do white men, largely in Broward County, who were gay, and African American women, largely in Miami-Dade County, who were straight. Both had huge complexity, multiple chronic conditions, and clinical complexity brought about by HIV or AIDS. But the African American women also faced huge social determinant barriers. Our nurse case managers, social workers, and outreach workers did a magnificent job of understanding the clinical and socioeconomic needs of our members. They taught me a lot. They taught me to follow the member and really understand where they were in life. And that's exactly what I did. And that is what really converted me to understanding that we had to pivot from to real care management in managing health. With that, we will take our second break, and when we come back, we will continue discussing the need to pivot to real care management. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We're doing a 5-part series on healthcare reform. We are in the 3rd episode, The Need to Pivot to Care Management and Truly Managing Care. So Part 8, Primary Care, the Missing Foundation. None of what I've just said works without strong primary care. And here is where the United States diverges sharply from other developed nations. We underinvest in primary care. We underpay primary care physicians. We have too many specialists and pay them too much. We overburden primary care practices with administrative requirements and complexity. And we expect primary care to function as the front line of prevention without giving it the tools, the time, or the incentives to do so effectively. In most high-performing health systems internationally, primary care is the foundation. In the United States, it has become an afterthought. That imbalance shows up everywhere. Higher emergency room utilization, higher hospitalization rates for preventable conditions, worse chronic disease control, and higher total healthcare costs. Part 9, filling in the outcome gap. The data consistently show that the United States underperforms on key population health measures. We have lower life expectancy compared to peer nations, higher rates of preventable hospitalizations, higher chronic disease prevalence, worse maternal and infant outcomes, and higher obesity rates. At the same time, we are not short on medical capability. We have world-class hospitals, we have leading-edge pharmaceuticals, we have extraordinary innovation capacity. But we lack a system that consistently converts those capabilities into population-level health outcomes. And that gap is where care management should live. If we zoom out a bit, the inefficiency becomes clear. We spend enormous resources adjudicating claims, managing prior auths, negotiating prices, and responding to acute episodes. But we underinvest in prevention, early intervention, behavioral health integration with primary care, and social support structures. In other words, we spend more time managing the system than managing health. With that, we will take our last break, and when we come back, we will continue discussing the need to pivot to real care management. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're doing a 5-part series on healthcare reform. We are in the 3rd episode, The Need to Pivot to Care Management and Truly Managing Health. So part 10, what a shift would look like. A true shift from utilization management to care management would require rebalancing incentives toward prevention, investing in primary care infrastructure, integrating behavioral health and physical health, aligning payment models with long-term outcomes, and using data to identify risks before crises occur. It would not eliminate utilization management, but it would reposition it. would become a backstop, not the centerpiece of what we do. Part 11, why this matters for cost and quality. This is not just about philosophy, it is about economics as well. Chronic disease drives the majority of healthcare spending. Hospitalizations drive the majority of cost spikes. Complications drive long-term system expense. Every prevented hospitalization, every avoided complication, every stabilized chronic condition represents both better outcomes and lower costs. That is the central insight here. We cannot control healthcare spending in America without controlling the trajectory of disease itself. Looking ahead, in our 4th episode, we'll talk about the 3rd pillar, affordable universal access through a uniquely American system of private delivery with public accountability. We will discuss employer coverage, safety net design, Medicaid and exchange reform, and what a unified access system could look like without adopting Medicare for all. And in our last episode 5, we will bring it all together and discuss what I believe could be a modern American healthcare reform grand bargain. That's it for today's episode of the Healthcare Labyrinth Podcast. Thanks for listening. If you enjoyed today's episode, be sure to subscribe and share it with colleagues interested in healthcare policy. You can also read the companion blogs on the Healthcare Labyrinth blog site, along with other installments in this series, published on May 26, May 28, June 4th, and June 12th. And if you want to go deeper, my book, The Healthcare Labyrinth, is available in print, ebook, and audiobook formats through major booksellers and at healthcarelabyrinth.com. Until next time, stay curious, stay skeptical, and keep navigating the healthcare labyrinth with me. We will find our way out together. Again, I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.